I am Jessica Levin. I am the Chief Program Officer for Let's Talk Menopause. We are a national nonprofit changing the conversation around menopause so women get the information they need and the healthcare they deserve. Our menopause talks are a central part of our education efforts, and you can find 16 of them on our website. They are incredible amount of information for you. I just wanted to emphasize all of these talks are for information purposes only. So please seek advice and guidance from your healthcare provider. Finally, just some last minute items. We turn off the chat to you. We will put links in, but if you have questions and answers, please include them in the Q&As, and Nina and Lauren will be answering them throughout the menopause talk and probably have time at the end also. And there's going to be a very brief poll at the end also. And we ask you to stay on to answer it. It is 3 short questions because we continually want to improve our offerings to you. So our topic today is on menopause and orgasms, come one, come all. And I personally am thrilled to bring you Nina Lorez Collins and Dr. Lauren Streicher. I will just say both of them have been instrumental to my learning in the menopause field. And I feel they're both amazing leaders for all of us. So Nina Collins, who will be the interviewer, she's an entrepreneur and author. And to many of us, she is famous for what she did to provide a source of information and an online community to women in perimenopause and menopause. She launched an online community called What Would Women, Virginia Woolf Do, for women over 40. And then that group spawned a book and a podcast called Raging Gracefully that I know I personally adored, Nina, and listened to all of them. And in fact, from listening to you do those podcasts, I have been wanting you to host one of our menopause talks because I just love the way you facilitate conversations. You're an incredible talent. And she then converted that into an app called The Wolfer. And then that ended up shifting. It was sold to Revel, a digital online platform for building community. And she was the chief creative officer until 2023. So thank you, Nina, for joining us. And then Dr. Lauren Streicher, who I hope you all have heard of. And if you haven't, you should, because she is all of our go-tos, especially for sex after menopause, whereas we've just been talking about, the challenges can get greater and greater, and our need for knowledge, like the boundless amount that Dr. Streicher has, it can get greater and greater also. So Dr. Streicher is a clinical professor of OBGYN at Northwestern, and she's the founding medical director of the Northwestern Medicine Center for Menopause and the Northwestern Medicine Center for Sexual Medicine. She serves on the editorial board of the journal Menopause, and she's also the senior research fellow for the Kinsey Institute, Indiana University. She's an author of multiple articles, scientific publications, and best-selling books. She has a top-rated podcast on menopause and midlife women and older. She is a well-known health expert on TV, and her upcoming book is Put the O Back in Your Mojo. She's also great at titles, by the way. A post-menopause guide to libido and orgasms. And that's scheduled to be released in 2024. And no doubt we will continue to, there it is.
Just got the mock-up.
We're going to continue to talk about that book, because if it reflects half of what Dr. Streicher knows, it will become a resource for everyone. So I wanted to now turn it over to both of you, and I want to thank you both for participating.
Hi, everyone. I'm thrilled to be here. And I just typed in the chat that I'm living in LA, and all of a sudden the gardeners just arrived, like literally 2 seconds ago. And now they're using the blower and God knows what. So I just closed my windows. I'm really, really sorry. Hopefully they won't be here long. It's a very small property and I'll just use mute. Anyway, thrilled to be here. Lauren, your work is amazing. And as you probably know, I mean, it's funny, you started really being big in the menopause space as the Wolfer was kind of winding down. So we never really crossed paths professionally, although we certainly know of each other. But I really admire your work, and I've listened to a bunch of your podcasts over the weekend, so I'm really glad to talk here. And I will say that when I think back to what would Virginia Woolf do, I think one of the things that we did was get women really talking about just vaginal changes and pain, vaginal pain in menopause. But actually, we didn't talk that much about women's inability to have orgasm. And I think that my sense is that becomes progressively more of a problem for me, at least. Like, it wasn't a problem 10 years ago in my late 40s when I was in perimenopause, but now at 54, it is becoming more of an issue. And I'm really glad that you talk about it honestly. I will say that when I've brought it up with my doctors, and I've had many, I have really good healthcare because I've worked really hard on this issue. And I love my current gynecologist, but I have to say the last 3 doctors I brought this up with, they all said to me, well, if you can orgasm with a vibrator, it's not your problem. It's the relationship. Like, it's the man, it's the chemistry, it's the guy. And I've realized that's not the case. I think it is all the things you talk about, which I want you to talk about here. It's nerve endings, it's blah, blah, blah. So let's just get into it. Let's talk about the fact that this is normal. This is common. I'd also love you to address, if you can, the fact that this doesn't happen for everyone, or do you think it does happen for everyone? Because my sense is it's like a lot of menopause symptoms, it's all over the map. And that a lot of women in their 50s and 60s, if they're with new lovers, for example, they don't have this problem. So anyway, I'm going to turn it over to you. Tell us why this happens. And you're muted, I think, because I can't hear you.
No,
now I can.
Muted.
Okay.
Now can you? Okay. Well, let me just circle back, because your first point is so important, that while there is more conversation around the fact that a lot of times women have pain with sexual activity, no one is ever talking about pleasure. And part of this, quite frankly, is we have this male-centric approach to sex. If a woman is having pain, she's going to say, nope, not tonight, honey. And that's going to impact on the guy. But if a woman is not able to have an orgasm, that doesn't get in the way of her ability to have sex. So we have a lot going on here to unpack, because not only has there never been an emphasis on female pleasure, but to your point, even good doctors have received no training in this. I certainly didn't. This is not something that they talked about during my residency or even later on in training. This is something that I investigated later on, because I was curious about, why is this relationship, as people are so often told. So let's start with, what is
one quick question. How old are you? And have you had this problem yourself?
I actually never talk about my own health when I talk about
Okay, just curious. Okay, I am having this problem.
Well, you know what? The reason I don't actually is because one of the things that's always kind of been an interesting thing for me is male doctors are never, ever, ever asked about their own health. They are asked as an expert, as a professional, what do you know about this? So the reason I make a point of never talking about myself isn't because I'm shy. I'm not. It's not because my own life is so personal. It's not. It's that, let's think about the role of a physician and an expert, and how women are very often relegated to, oh, I want to go to a female gynecologist because it's like talking to my girlfriend. No, you want to go to a female gynecologist because it's the smartest person who's the biggest expert who's going to help you. So that's why I've kind of made a point about never, when people say,
totally valid.
Well, what do you do? What do you do?
Yeah.
And my approach is the right question isn't what do you do, but if you were me, what would you do based on your expertise? So let's get back to the other question, which is,
why does this happen?
Is it relationship? Well, we have to talk about, what are the 4 components that are necessary in order to have an orgasm? Well, number 1 is arousal. Number 2 is physical touching of the clitoris, which is not always required, but it helps. Number 3 is good blood flow. And number 4 is, do you have nerve endings that are going to respond? Now, notice on that list, estrogen was not on that list. Think
Yeah.
about that. You know, this
Yeah.
idea that a lot of women say, well, I can't possibly have an orgasm post-menopause because you need estrogen to have an orgasm. You actually don't. It helps a lot because it
Mhm.
helps in terms of the health of the tissue and arousal and blood
Right.
flow, but you can have an orgasm without estrogen. So let's just circle back to the partner thing again. So number one, why is a partner important? Well, number one, a partner is important if you're having partnered sexual activity, because it would be nice if you knew where your clitoris was. Women partners tend to know. I'm just saying. Male
Mhm.
partners very often don't know. So there's that. There's the does he need a map
Right.
issue?
There is definitely a technique issue. There's no doubt about it.
Absolutely,
Right.
absolutely.
It's,
But
yeah.
number two is the first thing I mentioned, and that's arousal. We know that arousal is critically important to the ability to have an orgasm. Why? Because arousal is going to increase that all-important blood flow, which in turn is going to help those nerve endings be healthier and more responsive. The other reason that arousal is important is because if you are having pain, you are not going to have an orgasm.
Right. Well,
Because
arousal is so psychological, right?
absolutely. So it takes arousal to become lubricated, which in turn is going to help in terms of your ability to not have pain. It's not a guarantee, but it helps. So does the partner matter? Yeah, it does matter. And there's certainly a reason why many women are able to have an orgasm when they self-stimulate, when they masturbate, whether it's with their hands or vibrator or whatever, as opposed to with a person that there may be all kinds of other psychosocial things going on that are getting in the way of arousal. And you got to, hopefully you like the person or at least don't dislike them. So there is that, but that's why orgasm is complicated, because it's not just one thing.
Right. And that's also probably why when you're in a new relationship, I mean, a lot of women in their 50s and 60s post-divorce or whatever, if they're in new relationships, it might sometimes be easier because it's exciting. I mean, it's just.
That has been absolutely proven scientifically.
Right.
The monotony of monogamy is a real issue.
Right.
And
right. There are a lot of books written on this.
You, not only in the medical literature, but in my experience with patients, how many women tell me, I really am not interested. I like my partner. I love my husband. He's wonderful. He's my best friend. I hear this again and again, but I never think about sex. I'm not in the mood to have sex. I don't get particularly aroused. And then all of a sudden, the husband drops dead. They get the new partner. It's like, I can't stop having sex. Is it that the new guy has better technique? No. Is it that they love new guy more? No, it's new guy. So he's more exciting.
Exactly.
It's new. It's exciting.
But then, one of the questions, so are those women having menopausally induced problems, or is it just psychological? I mean, I guess one of the biggest problems I have, I want you to go more methodically through, these are the issues and what can you do? But it becomes like a lot of these menopausal problems, it's really hard to pinpoint the exact issue that's causing it. It's very frustrating.
And the answer is it's both. You can have a wonderful relationship and you can be aroused and you can be having a wonderful time and your nerve endings are just not firing. Why?
Right.
Well, because they're not firing because of aging. It's not just about hormones. We know that nerve endings are going to deteriorate with time throughout the body. So the nerve endings of an 80-year-old are not going to be as sensitive as the nerve endings of a 20-year-old. We know that because of aging, also blood flow is going to decrease. But the other thing that's going on with your typical menopause population, acknowledging that some women are very young when they enter menopause because of chemotherapy, premature menopause. But if you look at your typical population that is in your late 40s, early 50s, you are looking also at women that may have other medical problems, women that may have diabetes, that may have heart disease. Those are all things that are going to impact on the ability to have an orgasm. The other thing that's going on in this age group is medication.
Right, antidepressants.
And so let's talk about SSRIs for a minute, because what is the group that is the most likely to be taking an SSRI? Midlife women. Exactly. And what happens? You take this SSRI, and we know that up to 50% of women that take an SSRI have a problem with libido and have a problem with the ability to have an orgasm. Now, the good news is that sometimes this is temporary. In about 30% of women, that is not going to be an ongoing issue. It's going to get better on its own. But
Yeah.
in some women, it's not. It's not.
Right.
And they either need to, change the medication, and they obviously have to talk to their physician about doing that, maybe add a different medication. One of my podcast episodes that's coming up is about the use of Viagra in women off label, and how that can sometimes help with orgasm in the population of women that are taking antidepressants and SSRIs. But my point is that midlife, it's not just about menopause. There was also a very interesting article that came out about a year ago that specifically looked at the impact of menopause symptoms like hot flashes, insomnia, on the ability to have an orgasm. And there's a very, very high correlation. And when they
because when you're feeling crappy,
if you're feeling crappy, not to mention, if you haven't slept a decent night, had gotten a decent night's sleep in months, when you see that pillow, you're not thinking about sex. You're thinking tonight's maybe the night that I'm actually going to get some sleep.
No, I always say the reason I finally went on hormone therapy was because I wasn't sleeping at all. I was having so many hot flashes all night long, and I decided that's got to be worse for my health than going on the patch.
You are 1000% correct. And you probably weren't thinking about your sex life at the time, but I can pretty much guarantee that the minute you started getting a decent night's sleep, for a lot of women, that's going to be something that's going to wake up their libido. Right.
Yeah.
So
and
when
to the SSRI point, I want to say, like a lot of us have been on and off Prozac most of my adult life, and I don't think it ever really affected my sex drive. So I'm because I think one of the challenges for women is to try and narrow down really what the cause is. So as I listen to you, I'm pretty sure my issue is around good blood flow and nerves. I can still have an orgasm, but it's harder.
It takes longer, and it's not as satisfying.
A little longer. It's not right.
Yes. So when part of the puzzle of figuring out when someone is having problem is to take a very detailed history. So I don't know what happened when you went to your gynecologist and mentioned that you weren't able to have an orgasm, but it may be, or was having more difficulty, that the entire conversation was, well, if you can have an orgasm with a vibrator, you're good, as opposed to taking a very detailed history. When did this start? Was it something that happened very quickly? Was it a gradual onset? Are there certain circumstances when it's better or worse than other circumstances? So when it comes to an SSRI, there's a very big difference than, the woman who says like you, well, I've been on an SSRI my whole life and it's never really been a problem. Well, that's not the problem now. It's just not.
Exactly.
But the woman who says, I never had a problem. But the woman who just started and I went on an SSRI, and within 2 weeks, I started having an issue. It's your SSRI.
Yeah. And then she needs
to be more than one thing, but very clearly that was the thing. So
that's a really good point. I just want to pause for a sec so our audience really thinks about that. It's really difficult to find a doctor who's actually going to walk through this with you. And you talk in one of your podcasts about sometimes it's good to, if this is an issue for you and you really want to conquer it, sometimes you have to go find a sexual health doctor, because I would say the vast majority of gynecologists are not going to be helpful with this.
They're not.
That's fair. Yeah.
And it's always interesting to me that if a family member has an issue, whether it's a serious cancer or another serious medical problem, or that you can't get pregnant and you want to see a fertility specialist, no brainer. People do that. But the minute it's about menopause or sexual medicine, there's this idea of, oh, well, this is just what happens when you get older. And yeah, it does happen when you get older, but it doesn't mean that there aren't solutions. And in fact, when I started writing my books, it was with the idea of my books are meant to be solution oriented. I mean, I could do a textbook about orgasm. People don't really want that textbook. They want to know what to do. So while I do give the background and all that in my upcoming book, it's really solution oriented. If you are on an SSRI, this is what you do. If it's because you have cardiovascular disease, this is what you do. If you are diabetic, this is what you do. If this is a result of chemotherapy and radiation, this is what you do. Because that's what people want to know. What do I do?
It sounds amazing. So I don't want to take away from sales of your upcoming book, can we talk a little bit about what you can do? Like the
Sure.
basics, like if it's, because I want to talk about estrogen a little bit, like if it's
Yeah.
good blood flow,
Yeah.
is topical estrogen the solution or one of the
It can be.
solutions?
It's one of the solutions. So the general approach is you want to do two things. One is you want to increase the health of your clitoris. And the second thing is you want to make sure that you're using the kind of stimulation that's actually going to fire off those neurons. So when we look at the health of the clitoris, it really does come down to blood flow, because what's going to get those neurons, those all important neurons, to be more sensitive is if they have better blood flow. Now, do you remember a few months ago when that news came out about they did some research and they found that there's 10,000 nerve endings in the clitoris, and everyone's like, isn't this wonderful? And I'm thinking,
Yeah.
are you kidding? This is terrible news, because the clitoris is very small. And the more nerve endings there are, the smaller those nerves are, and the more likely they are to not be healthy as time goes on, because the teeny nerve endings
Wow.
are the ones that are the first to go. So while everyone's like
Oh.
celebrating, oh, gee, there's so many nerve endings, I'm thinking, this is not good. This is not good. So what do we do to make those nerve endings? What do we do to increase blood flow? Well, anything that is going to topically increase blood flow is going to help. So topical estrogen. Now, let's talk about topical estrogen for a minute. When we talk about topical estrogen, and we know that there's a number of different options for local vaginal estrogen. We have a cream, we have a vaginal ring, we have a suppository, we have little tablets. And the problem with those forms of local vaginal estrogen is that some of them just go in the vagina. They're not going to help the opening of the vagina. They're not going to help bladder function as much because they're not going to the urethra.
Right.
And they are certainly not going to particularly help the clitoris because they are working locally.
Mhm.
And so it's not enough to put estrogen in your vagina. You need to put it directly on the clitoris. How do you do that? Well, the only way you can really do it is with the cream. I have no problem with the
estradiol.
inserts and the rings and all that are convenient, and they're not messy, but they're not going to do a whole lot for your clitoris. So I am a big advocate of dual treatment, meaning you may want to put something in your vagina like a suppository or a ring, and that's going to help in terms of your vaginal health and your ability to have comfortable penetrative sex with a toy or a penis. But you also then need to get a second prescription for vaginal estrogen cream. And you take a little bit and put it on your finger, and you go north and you actually apply it to your clitoris. And that's something that you don't do right before you have sex. You do it on a regular basis, because what you're trying to do is increase the health of the tissue. Now, is there
a quick question? When I take topical estrogen, doctors always say it doesn't cross like the blood barrier or whatever,
Yeah.
but when I take it, my breasts start to really hurt. And so it freaks me out. So I stopped taking it.
Yeah. So it's called local vaginal estrogen because it primarily works locally. And does it get absorbed? It does. But what's counterintuitive, and this is so interesting, but when you think about it, it makes sense. A lot of women will say, well, I don't really want to use very much local estrogen because I'm worried that it's going to impact on my breasts or cause breast cancer, which it will not. Or if you have breast cancer, that it's going to be dangerous. So what they do is they use the smallest amount possible. That is the worst thing you can do, because if the tissue is thin and you put some estrogen on there, it's going to go right through. But if the tissue is thick, it's going to stay put. How do you make the tissue thick? You use a lot of it. So if you look at the data of absorption of a local vaginal estrogen, we have charts. There is data that exists that when you very first start using it, your blood levels are going to be a little bit higher for about 2 weeks, because it's going to go through that tissue paper, thin tissue, and get right into your bloodstream. But then if you measure blood levels 2 weeks later, it's basically non-existent. But what happens is women are told by their physicians or their nurse practitioners, whoever, that you should use the local vaginal estrogen every day for 2 weeks and then you go to a maintenance dose, which is going to be usually twice a week. Right. And they're thinking, well, I'm not going to do that. I'm going to do less. I'm going to
That's what I did.
Yeah. I'm going to start with the twice a week. Big mistake.
Bad.
Big mistake.
Okay.
Not only is it not going to work well for you, but you're going to get more absorption and you might get that breast tenderness, which is going to freak you out. And then you're going to stop.
That's
So
exactly what happened to me. This is so
exactly.
helpful. Okay, I'm going to call my doctor today and get a new prescription and try it because, okay, so just use it a lot for 2 weeks and then go down to a maintenance dose.
That's right.
And
I
if
always
my
talk about
breasts
repair
hurt,
and
just-
maintenance. And I talk about in my first book, my first book, which is the sliding away book, Turning Back the Clock on Your Vagina.
You do have great
And-
titles, by the way. Your titles are awesome.
My daughter, who's also a sex therapist
Yeah.
and a writer, a journalist, she sometimes helps me with the title, but this one I came up with on my own. But
Very good.
you know, so it's oh, I lost my train of thought on that one where I was
Okay, so well, I just want one more question. So if my breasts hurt using it, will that just go away then?
Yeah, it'll go away because the absorption will be less. Oh, I know what I was going to is that when we think in terms of fixing thin, dry tissue, vaginal, vulvar, clitoral, there's repair and there's maintenance, and they're different. You know, when you're looking at someone who is 5-10 years into menopause and their tissue is really thin and really dry, they got to fix it. You got to fix it first. So you do the higher dose stuff to repair. And then once you get to where things are working well and the tissue is healthy, then you go to maintenance. And that's such an important concept because too often women go right to the maintenance dose and then it doesn't work.
And it really doesn't do it. It's really a helpful distinction.
They don't know why.
This is exactly the mistake I made. So
the other thing you always hear is use it or lose it. And this is also problematic because use it or lose it is fine if the tissue is healthy and things are working great and things feel good. Yeah, absolutely. If you have more arousal, if you have more sexual activity, it's going to increase blood flow. It's going to help keep that tissue healthy. But if the tissue is thin and dry and you're having pain, the worst thing you can do is
you're going to damage yourself
to have sex when it hurts, because then your pelvic floor muscles are going to go into, are you kidding mode? And they're going to tighten up and it's going to continue to get so bad that intercourse is going to be out of the question.
Not to mention that psychologically, you're totally traumatizing yourself.
Right. You're not supposed to have pain. You're supposed to have pleasure.
Right. I want to just tell the people in the Q&A that I will get to your questions. I just want to continue on one train of thought for a sec. So what about the nerve ending issue, dying nerves? Is there anything you can do about that?
Well, number one, again, is to increase the blood flow. And estrogen's not the only way. You know, certainly there are a lot of other approaches to increasing blood flow. We're even looking at CBD, actually, applying local CBD to the clitoris, which we don't have good data on that. I'm very data driven in general, but with CBD, we don't have the data other than to know that it is a vasodilator. And anecdotally, it does appear to help with orgasm when you apply directly to the clitoris.
I'm super cynical about you have to find the right product. There's so many CBD products. And if you, I don't know how you find the right one, but
yeah, and I will have some guidance to that, you know, certainly in the book, and also I have an upcoming podcast on that. But there's other medications that are also vasodilators, which are there's no FDA approved products for female orgasm. These are all off label, which doesn't mean that they're not safe and that they're not appropriate, but it's not something that you're going to go to your doctor and say, oh, can you give me something that's going to help with orgasm, because there now are no FDA approved products. So, but the other thing about nerve endings, and this is the aha moment, this is the kind of takeaway, is the understanding that we have different kinds of nerve endings, and these different nerve endings actually age differently. And it turns out that the nerve endings that respond to vibration are the ones that also age the best. They last the longest. So if you are saying, okay, I used to have an orgasm with oral sex or with soft stroking, and now it's not working, I'm only able to orgasm using a vibrator. You're not crazy. That's your nerve ending saying, the ones that work the best are the ones with vibration. So your gynecologist was partially right in that, saying if you're able to have an orgasm with a vibrator, then you're good to go. But it's not about relationship. It's about, this is the biology of your nerve endings. And so a lot of the work that needs to be done is about incorporating a vibrator into your sexual activity, whether it's solo activity or partnered activity. And in fact, I don't call vibrators toys. I call them tools, because a toy
Like
is
that.
something that makes it more fun. This isn't to make sex pleasurable. This is to make sex possible. This is
Effective.
to make orgasm possible. So this is
Right.
a tool, the same way as a lubricant. You don't use lubricant because it's more fun. I mean, if you're 20, maybe you do, but if you're 50 or 60, you certainly don't. You use it because it makes sex possible.
You need it. Yeah.
You need it.
Yeah.
And I think that that's a real paradigm shift, is to get into the mindset, oh, a vibrator is actually a tool that I
Well,
need
I think
to
that's
keep
something
things
that's
going.
Yeah, I think that's something that is really changing in a nice way in our culture. 10 years ago, no one ever mentioned vibrators in TV and movies, and now they're all over the place. And
Yeah.
I think a lot of men our age, I mean, my boyfriend's in his 60s, a lot of men, older men, are more hesitant maybe about them. Younger men, I think it's now really part of the culture, and that's
It
great.
is. Yeah.
Yeah.
And part of it, I think, is the notion that men are admitting that they need help too, that they need to take their Cialis, they need to take their Viagra. And just as they need something to facilitate their ability to maintain an erection and have an orgasm, women do as well. But what women are up against that makes it really tricky is ageism, because men, if they're in their 50s, 60s, 70s, they're supposed to be virile and sexual and, have 20-year-old girlfriends and all that kind of stuff. And what women are battling a lot, particularly if they're single, as opposed to being in a long-term relationship, I'm making a generalization, but the idea of, boy, I'm competing with much younger women. I'm out there dating, I'm 50, 60 years old, and the men that I'm most interested in are going out with the 30 and 40-year-olds. So I have to do my best between my, Botox and coloring my hair and all the things that women do to maintain that youthfulness. And then all of a sudden, when you say, hey, I can't
I
have
need a
an orgasm
vibrator.
without a vibrator, that is suddenly putting them into a different, so a lot of what we do is the language. And in fact, in my upcoming book, I'm doing something I've never done before. And I mentioned my daughter, Rachel Zara, who's a sex therapist. She's a PhD in clinical sexology.
You must be so proud. That's so cool.
I'm very proud. And we do a lot of things together, including we just did a podcast together on faking orgasm, which was really fun.
That is so great.
It is great. But so I'm having her write a few chapters in the book. I mean, I write unlike other books by doctors who, quite frankly, hire writers, I write every word myself. And this is going to be the first time that I've ever had someone else write something in my book, because I really wanted Rachel to address the language. How do you introduce a vibrator? How do you make it so that it's a positive, not a negative?
Yeah, and hearing that from a young woman is probably really helpful, because there is a
Mhm.
different level of acceptance and familiarity, and that's really smart. I can't
Yeah,
wait to read your book.
and she also, and the thing that's really wonderful about what she does is that she works with all ages. She has clients who are in their 20s and 30s, but she worked at the Menopause Center that I started. She was one of our sex therapists. So she was working with women who were 50, 60, 70, 80, 90, and really has a talent in terms of understanding what's going on in those relationships as well.
That is very cool. I'm going to go to a few questions, and then I want to come back to other remedies, but I don't want to get off this call without talking about the whole Viagra thing for women, because that's really interesting.
Yeah.
One woman says, what is your perspective on vaginal moisturizers with hyaluronic acid? I just purchased Gynatrof.
Yeah. Hyaluronic acid is an excellent, excellent product. When we think in terms of moisturizers, one of the things that's very confusing is what's the difference between a lubricant and a moisturizer, because they're not the same thing. And from marketing, it's hard to know, because one of the things I realized a long time ago is products that are lubricants are very often advertised as moisturizers. Why? Because women are comfortable with the idea of a moisturizer. A moisturizer is something that you put on your face, you put on your hands, you put on your feet. So putting it in your vagina, on your vulva seems like okay, as opposed to a lubricant, which is very clearly for sex and nothing else. So a lot of companies call things moisturizers that are lubricants. So what's the difference? A lubricant is to be applied at the time of sexual activity to decrease friction, to grease the skids, to make things more slippery, but it does not change the tissue. A moisturizer, on the other hand, is something that needs to be used on a regular basis to increase the water content of the tissue and to make it, and to increase your natural lubrication. There's basically only two kinds of long-acting vaginal moisturizers that have been shown in scientific studies to work. One is hyaluronic acid. Hyaluronic acid is an excellent product. And the other is the ingredient that's found in Replen's long-acting moisturizer. And both of those products work very, very well. And the hyaluronic acid stuff, one of the things that I would advise when using a product with hyaluronic acid is don't just save it for when you're having sex. Use it on a regular basis, 2, 3, even 4 times a week. Just like you would moisturize your face every day, moisturize your vagina a lot because there's no downside. And again, don't just put it inside the vagina. Make sure that you're putting it on the vestibule, the opening. A lot of people forget that. And it doesn't matter how nice the room is if you can't get through the door. So you have to be sure to put that moisturizer on the opening. And then, go north and put some on your clitoris. We don't have great data that it's going to work. But again, it's making the tissue healthier. It can't hurt, and it may help.
Yeah, I've used Replens and really like it. And I'm a big fan of coconut oil. I use it every day, all the time.
Well, coconut oil, this is the deal with coconut oil. A lot of people use coconut oil as a lubricant. And if it works for you and you like it, go for it. No problem. Smells nice, tastes nice.
I use it as a moisturizer, not as a lubricant.
Yeah, there's no data that shows that it's absorbed into the tissue. And the other thing is, for some people, when they use it as a lubricant, number one is it's just too thin. It's not thick enough. It's not going to do what it needs to do. And the other is, and there's not a lot of science, but there's one article that shows that it increases the risk of vaginitis. So if someone is using it and it's working for them, go for it. But it's not on my number one recommended list because of those issues.
Yeah. All right. Another question. Is there an estrogen vaginal cream that can safely be used for someone who gets aura migraines? Migraine not triggered by hormones.
Yes, all of them. This idea, the problem is there's something called class labeling that the FDA requires that every single product that has estrogen in it gets the same warning. So when you buy vaginal estrogen and it says things like it's going to give you dementia, it's going to give you breast cancer, it's going to give you blood clots, it's going to give you migraine headaches. Not only do we not know that that's not the case, we know it's not. We have very, very good data. And there's been a huge move to get those ridiculous warnings off the label. There is not one shred of evidence that shows that using a local vaginal estrogen, any of them, is going to increase the risk of having a migraine and migraine with aura, or it's going to increase your risk of having a stroke. That's one of the concerns. Women that have migraine with aura are told, well, you have an increased risk of having a stroke if you use estrogen. That is not the case with a local vaginal estrogen. It is just not. So go for it. I mean, talk to your doctor, but there's no data to support that.
Great. Someone else says, my insurance no longer covers my topical estrogel, so I was forced to switch to oral estrogen in pill form. Is it just as effective?
It depends on, so this is an ongoing issue that we're dealing with insurance companies, of course. And what you're talking about there is systemic estrogen, not local vaginal. So when you look at systemic estrogens, there's 3 ways to get that into your body, meaning it's going to affect your whole body, which is a good thing, not just the genitals. So there's oral estrogen, there's transdermal, which is what this listener is talking about. And this can be a patch, a gel, a cream that's applied to the skin. And then there's also a vaginal ring that is a higher dose, a systemic dose than the local vaginal estrogens we've been talking about. Now, the major advantage of using the transdermal cream gel that she's talking about is that it's not metabolized by the liver. And as a result of that, there's not going to have that increased risk of blood clots that you see with oral, which is small, but it is there. And there's some other advantages as well. But the real question, her question is it going to work as well?
Is it as effective?
And the answer is yes, it is just as effective when it comes to sleep, when it comes to bone health, when it comes to hot flashes. The one thing it's not as effective in, interestingly, is libido. And the reason is, without getting too sciencey about this, but there's something, it's a protein in your body called sex hormone binding globulin, which binds estrogen so that it determines how much is available. And it turns out that oral estrogen increases sex hormone binding globulin, which means that it's going to bind up some of your estrogen and your testosterone so that you're not going to get as much help with your libido as you are theoretically with a transdermal product. So
Okay,
when
that
she
was
says,
very
is it,
sciencey, but okay.
yeah, but so if someone says, does it work as well? It depends on what you're treating. You know, what do you want it to work
Yep.
as well for? Is
That
it going to
makes
work
total
as well?
sense.
But also on today's topic, when we talk about, okay, we've talked so much about local vaginal estrogen and how it's going to help the vaginal and vulvar tissue and clitoral tissue. What about if you're using systemic estrogen? Is that going to do it? And the answer is, in about 75 to 80% of cases, yes. If you are using a systemic estrogen for bone health and your hot flashes, then 75 to 80% of women are also going to have adequate support of their genitals. However, about 20 to 25% of women are not. And they're also going to need to add on a local vaginal estrogen product or DHEA. And no, it's not too much estrogen. A lot of people say, well, isn't that too much? And then if you weren't thinking about that, you will when your insurance company writes you the nastygram that says, oh my God, you're already taking estrogen. You can't take more, like you're going to explode or something. And in fact, we know that it is perfectly safe to do so.
Interesting. All right. Well, that brings me to a question that I was going to bring up anyway, and that's in the chat, is what are your feelings about testosterone pellets?
Let me divide this into two parts. Okay. Testosterone therapy is absolutely appropriate and safe and effective to use in postmenopause women to treat libido. It's not going to work for everybody, but it can be safe and it can be effective. Pellets are malpractice. Pellets should be off the market. Pellets are so dangerous. And this isn't just my opinion. This is the science. This is why the Menopause Society has come out loud and clear saying, do not use pellets. I mean, we could do a whole hour on pellets. So I don't want to get off on my pellet tangent.
For anyone who doesn't know, pellets are these that they get injected in your ass, right? In your butt, and they last
chip in the hip is what I call them.
Out.
You can't take them out. They have to wait for them to go away on their own. And they sound, I mean, this is the thing. The doctors that recommend them make them sound so wonderful. And what I will tell you is, for anyone who gets a pellet, they're like, this is amazing. I feel so good. I have a great libido. I have so much energy. I love it. And you will initially. And then as time goes on, you need to higher doses. We see problems such as increased hair growth, enlargement of the clitoris. But the big issue with the pellets is the increased risk of uterine cancer. I do have an entire podcast on that. And I think for anyone who's using pellets, it's very important. It's the name of the podcast, I remember something about compounding hormone therapy, but the pellets are a problem. Testosterone, I have another podcast called Say Yes to Testosterone that goes through all of this in more detail.
So this is using testosterone creams in a safe way.
Exactly, a transdermal testosterone cream or gel that needs to be given in a very specific way by someone who knows what they're doing.
Someone who really
and it is off label. It is not FDA approved, not because it's not safe and effective, more for political and financial reasons, but it is appropriate in certain women.
So again, a challenge to find someone who really knows how to administer what they're doing. And what is DHEA? I'm always a little confused.
DHEA is interesting. DHEA is a building block for both estrogen and testosterone, meaning our body uses DHEA to form estrogen and testosterone. And what we know is that if you use DHEA in the vagina, it will actually cause a process to occur in the cells of the vagina to make a little estrogen and testosterone. And we know that vaginal DHEA works as well, and maybe even better than using estrogen. This is different than oral DHEA, which does nothing. So
vaginal DHEA is a repository that you can get.
So there's an FDA approved version of DHEA, which is called Intra Rosa. And this is a suppository. Right. And then you can do it a compounded version. But, the thing about it is that we always forget that it's not just estrogen receptors in the vagina, there's also testosterone receptors. And testosterone receptors are very, very important in the vagina as far as helping with lubrication. And in fact, in our menopause clinic, when we would see women who had failed using a local vaginal estrogen, meaning they were using the local vaginal estrogen and they were still having dryness, they were still having problems, we would give them a local vaginal testosterone as well, combined with the estrogen, and they would do much better. And we forget about that component. So it, you know, like anything, nothing's going to work for everybody, which is why it's nice that we have many choices. But for many women, using DHEA vaginally is the answer. And it also does seem to help libido beyond what you would find just from helping lubrication. You know, we know that if you lubricate better, your libido is going to be better, no matter what product you use.
Right.
But a DHEA given vaginally also appears to be a little boost to libido beyond what you're going to get from the lubrication.
Right,
so it's a wonderful product, but not oral. The oral stuff is a waste of money. It does nothing.
Okay, so the vaginal one for those listening is called Interosa, and you can get it from your doctor. So a couple of people in the chat in the Q&A have asked the age-old question of, you know, is it too late to go on HRT when I'm 58 or 60? Is it safe to start the estrogen patch at any point? I know there's a lot of debate about this. I mean, now, you know, anyway, you should answer it as a doctor.
Let's start with vaginal estrogen. There is no expiration date on your vagina. You can start a local vaginal estrogen when you are 90 and it's fine. And quite frankly, a lot of times we're giving it to older women because of the bladder issues, which we're not talking about today. But, you know, we do know that vaginal estrogen is really critically important for women that have recurrent urinary tract infections and urgency and all that. So we can start that anytime. And then there's no debate about that. That is not controversial. You can start a local vaginal estrogen at any age. The debate is systemic estrogen for hot flashes, et cetera. And the reason of this debate is because in the WHI, the study that came out years ago that showed that there were problems, the overwhelming majority of women in that study were over the age of 65. And when you looked at the women that were actually having trouble in terms of blood clots, cardiovascular issues, it was the over 65 group, or women that were more than 10 years out from when they entered menopause. So we know that the safest, best time to start systemic hormone therapy is in the 50 to 60-year-old years, or within 10 years of going into menopause if you start earlier. But, and this is the caveat, it's not like you can't start it later. Of course you can, but there's going to be certain risks that go along with it. So it becomes very individualized. Who is this woman? Why does she want to take it? Is it because of hot flashes? Is it because of bone health? Is it because of cognitive function? What are you trying to accomplish? And then you can determine, is it safe and is it appropriate? So I would never make a blanket statement that, yes, it's totally fine for women in their 60s or 70s to start systemic estrogen. But what I will say is that in individual cases, you know, when we talk about the whole risk benefit, shared decision-making thing, yes, there are women that it is reasonable and appropriate to start systemic hormone therapy in their 60s. But again, and this is our recurrent theme, you have to have a physician or a practitioner who gets this.
Yeah, I mean, I hear stories a lot. I know a lot of women who have told me that their doctor won't let them stay on the patch after age 60, and they've had to try and find a new doctor who will.
Well, that's different. Okay, so there's a difference between staying on and starting. Okay, so let's talk about staying on. If you are taking hormone therapy, I don't care what kind it is, oral, transdermal, whatever, the age to stop is when you die.
So you can keep going.
Not only should you, but there's benefit. And the reason is if the only thing that you were treating is your hot flashes, well, for the majority of women, they're done with hot flashes after about 10 years. But when you look at the impact and the benefits of estrogen on your bones, on your brain, on your bladder, really virtually every cell in your body, those benefits are going to continue. And it's not like guys who are taking testosterone for whatever reason that they say, okay, stop at 65. They're going to stay on forever. And when you hear this mantra of using estrogen for the lowest dose at the shortest amount of time, that was never based on science. That was marketing. That was ridiculous. There's no science behind it. And even the Menopause Society, which I'm very involved in, of course, but they're very, very conservative, sometimes too conservative for my taste. But even the Menopause Society says it's fine to stay on lifelong. You know, they say, you know, you talk about it with your physician, blah, blah, blah. But they at no point do they say that you need to go off. So if someone is telling you, okay, you've been on it for 5 years or 10 years or 15 years or whatever arbitrary number they've pulled up and said you have to go off now, that's simply not supported by
They're
the
just
science.
not up to date with
it's just not supported by the science, you know.
This is a real problem because a lot of doctors do tell women they have to go off.
That's right. And it's because they don't know, and especially internists. I mean, I hate to blame an entire group, but what happens is that the overwhelming majority of women over the age of 60 are no longer seeing a gynecologist. If they're seeing any doctor, it's going to be an internist, because most women only have one doctor, and they're going to have, you know, an internist as their doctor, who in most cases, there are exceptions, of course, but in most cases, these doctors are not menopause experts, and they're very uncomfortable writing a prescription for estrogen. So they are going to be the first ones to say, you've been taking it for 10 years. It is time to go off. And that is just not the case.
All right. So just to be very clear, once you're on it, you can stay on it. But the question of whether you start it after 60 is very individual, and you have to have
individual.
The other doctor who knows what they're doing.
And the other thing that we don't have a really good answer to is the woman who is on it and then goes off. And now she's been off for 10 years, but wants to go back on. We don't have that data. So again, it's very individualized.
Interesting. All right. Well, that's helpful. That's really helpful. Let's see. I'm on HRT, not me, this is a question. I'm on HRT for bone health. My doctor retired and I felt like a drug addict as I went to doctor to try and get my prescription renewed. Oh, yeah, that can be hard. I mean, okay, sorry, that's not really a question, but yes, it's hard to find a good doctor who's going to help.
But let's talk about for bone health for a second, because I actually, it hasn't gone live yet, but I just taped an entire podcast on using hormone therapy specifically for bone health. And one of the questions that I actually had a guest for this one. Sometimes I do them alone. Sometimes I have a guest, but my guest on this one was Dr. Christy Tufta-Sapri, who I think maybe has done a menopause talk for Let's Talk Menopause. I'm not sure. She's so good. She's the bone guru, I say. And so she was my guest, and I specifically said to her, okay, is it okay for someone just to take hormone therapy just for their bones and to stay on it forever? And she said, absolutely, and laid out the science behind it and what we know. So for the woman who wrote with that question, stay tuned. I think I'm airing that one probably in mid-January. And
that's really
again, it's a challenge of finding a doctor who understands it.
Right. So you have to find the right doctor. I mean, that is a theme that comes up again and again. Someone else says, can you please recommend some vaginal topical creams? And can they also help with bone health? So same question. So estrogen, so it's Vagifem, it's estradiol, estradiol is the real cream, right? The vaginal cream.
There's estradiol cream, which comes in generic, and there's different trade names. When we look at tablets, Vagifem is the trade name. I don't work for any of these companies. I always make a point of saying I'm completely unbiased. I'm just giving you the science. Vagifem also is the little tablet that comes in generic as well. The ring is called Est Ring, which is a local vaginal estrogen, as opposed to Fem Ring that I mentioned before. That's actually systemic. And when we think in terms of the advantage of them is that, as we talked about earlier, they're not absorbed, which means virtually anyone can use them. The disadvantage, they're not going to do a thing for your hot flashes, for your bone health, for your skin, anything. It is a local vaginal estrogen, and it is only going to work where you put it.
Right. Okay. Is there a substitute? I know Jessica's hopping on, we're coming to the end, but is there a substitute for Interosa? One woman says that Interosa is incredibly expensive for many women.
You can get it compounded. And compounding meaning compounding pharmacies mix up things that are not FDA approved, and you have to find a physician or a nurse practitioner who is going to prescribe it for you. Some of the telehealth companies also are getting into that world and are very helpful.
Great. Thank you so much. This has been great.
We
Well,
covered a lot of ground.
Dr. Streicher, I have one question about that, because we've heard a lot of doctors really advise against compounding pharmacy
Yes.
for that. So is
Yes.
there something you can say very briefly about
Very
that?
briefly, I use compounding pharmacies only for things that I cannot get commercially in general. That's the only advantage to compounding. You need to know your compounding pharmacy. And the big issue, quite frankly, is not in the compounding pharmacy, it's in the person prescribing. And if you have someone who's prescribing pellets who's saying, oh, you have to get a compounded hormone cream and all of that, you generally, you don't. And there's certainly this idea that it's safer or better is just not true. But a compounding pharmacy is useful if you cannot otherwise get it.
Thank
I
you.
once got, this is like my favorite thing to say. I once got vaginal Valium from a compounding pharmacy because I was having like spasms,
Right.
like or spasms, and it
Valium
was
for your vagina. Love it.
Oh my God, Valium for your vagina was
Okay.
fantastic.
So, as I told you all, both Nina and Dr. Streicher are incredible and incredible resources for us. And we hope you loved listening to them as much as we did. And so I just wanted to thank both of you for joining us today and for giving us all so much information. We definitely want both of you to come back. And I know personally I could just keep listening to you both for forever. So thank you so much. Feel free to sign